Thank you. I'm glad to be able to present today. I'm going to be presenting on some work that we've been doing looking at geographic variation in HPV vaccination. So the objectives of my talk today will be to provide a little bit of information on how HPV immunization surveillance is typically done. And then I'm going to talk a little bit about two papers that we have been working on in this area. One, a systematic review in which we're looking at papers that looked at area level variation in HPV vaccination. And another one where we're using GIS or geospatial analysis to look at identifying areas of disparities in HPV vaccination coverage. So many of you are familiar with the NIS Teens Survey. It collects data from parents and on whether or not their child has been vaccinated. And then vaccination history is confirmed by the provider via mailed survey. So one of the pros of this is that it's considered really a reliable estimate at the national level. And sometimes for the states, they use this estimate too to surveil their coverage. The con is that the sample size per state is somewhat limited. And so with this limited power, it's hard to characterize smaller geographic areas, such as at the zip code level or even at the county level. Another method of surveilling HPV vaccination might be to use the state immunization registries. And many states have immunization registries. Providers report data on vaccines that they administer to children. Some of the pros of this is that it can be used to track the increase or decrease in immunization at small area levels. And it's really possible to identify high or low levels of immunization controlling for population size. And in many cases, residential addresses are available, so you can look at the places where children live where immunization is either high or low. And then sometimes data on the provider type and location where the vaccine was administered can be available, but not all state registries will release this information. Some of the cons of using this type of surveillance method is the denominator problem. Oftentimes, it's difficult to determine the population prevalence for small locations if you only have data on the number of vaccines given, but you don't have any data on the number of teens that might be eligible. So data can be also very difficult to work with, sometimes millions of cases, and the data can be inaccurate. Sometimes providers without an EHR, it's difficult for the state to gain those data, and then provider compliance could also be low in some areas. So those are just some of the cons of that method. Another method might be to use electronic health records or claims data. This can be quite useful at identifying at a systems level how well and where vaccines are being administered. And it can be combined with other data to understand provider characteristics related to uptake. Now, the cons are that you still face this denominator problem, as I mentioned before, and also sometimes without special approval, the address of the teen or the child may not be available. So where the vaccine was administered may not represent where education efforts might need to be targeted, especially if patients travel far to see a provider. So this is just a snapshot of the NIS Teens data. You can see here that I'm just highlighting Virginia, that's where I'm from, but you can see that our up-to-date coverage among females is around 41%. But look at the confidence interval, it's very wide, and it's really only a sample size of 129 females. And then for the males, it's 118. So very small sample size that is representing the full state for that method. So we were very interested in understanding what others were doing in this space, looking at how are people assessing area level variation in uptake. So we reviewed a number of different studies that looked at this research question, and we sought to conduct a systematic review and summarize findings from these studies. We used a keyword search through a number of different databases, including PubMed and others. And we included studies that provided information on HPV vaccination by geographic area level variables. And so we culled our list down to 25 articles from 733 that we identified. So some of the key findings were that most studies did focus on these large US geographic regions, and fewer looked at areas within the state. There was only three or four articles that reported on state level variation. Across these studies, the average HPV vaccination initiation was around 41%, and completion was around 23%. Some of the studies that looked at regions of the US, they were consistent in finding lower coverage in the southern region of the US, but there was inconsistencies with respect to other regions in the US, such as in the West or in the Northeast. Studies that looked at poverty at the zip code level did find that poverty was associated with higher vaccination rates. And with regard to rural and urban, there were some studies that looked at these differences, and there were some consistent results suggesting higher uptake in more populated areas, especially for boys. With regard to race ethnicity, many of the studies that looked at this did find that higher coverage was found in communities with majority Hispanic populations, and then there were mixed results with regard to communities with majority Black populations. And finally, studies were consistent in finding that there was lower initiation with higher area level uninsured and provider shortages. So these key findings suggest that one, well, there really aren't that many studies in this area. We only were able to identify 25 studies. And across these studies, they varied in the ways in which they were defining some of the metrics and initiation and some of the geospatial areas. So it was very difficult to synthesize findings across these studies. So we recommend that we need to standardize some of our definitions and improve the methods that we're using for looking at area level variation. And we need to incorporate spatial regression modeling approaches as well. Finally, there's a definite need to obtain data on vaccination coverage at smaller geographic levels. So the next study that we conducted was really to address the small area analysis, looking at Virginia in particular. And so we wanted to use geospatial analysis. So as I mentioned, there's some of the shortcomings of some of the other studies. And so our aim was really to model the variation in vaccination rates among boys and girls within Virginia and identify areas with depressed vaccination coverage and determine if there were neighborhood socioeconomic variables that might explain variation in HPV vaccination. The data source that we used was data from the Virginia Immunization Registry. We created an analytic sample of individuals born in 2001, 2002, and 2003 who were about HPV vaccination age ready in 2010 and 2018. So we took all the immunization records that were present for this birth cohort at the time, so their birth immunizations, and traced them into adolescence to look at whether or not they had received an HPV vaccination during their eligibility period. We used residential zip codes, and they were linked with several area level variables, including poverty, a number of 15 different area level variables. We used Bayesian hierarchical spatial regression models to identify geographic disparities in HPV. And then we used machine learning approaches to identify area level variables related to vaccination completion. So you can see here in this slide that lighter shades show lower vaccination completion. And overall, girls had high completion probabilities. Around 29% of girls and around 24% of boys had completed the HPV series. This map shows the data a little bit differently. The areas that are in dark red are areas of lowest vaccination completion. So you can see that in the Southwest, the northwestern parts, and areas of the Norfolk and Virginia Beach area have low vaccination coverage, as well as this large swath running from south of Alexandria through Sussex County. And with a few exceptions, really aren't that many differences between completion for boys and girls. So it's very similar maps for boys and girls. When we looked at what are the factors that predict whether or not there was vaccination completion, what we did find is that there was a higher probability of vaccination completion that was associated with a greater population density, a higher percentage of Hispanic population, consistent with our review article, and greater racial ethnic diversity, and higher percentage of residents with a college education. This is suggesting that vaccination completion is in areas of urban and suburban counties and zip codes. We found lower probability of completion associated with the average number of vehicles owned per household. And that might suggest that in more rural areas where rural residents tend to own more vehicles, farm vehicles, other work vehicles and such, that vaccination completion was lower. So of all the variables that we included, these are the ones that were significant in the model. So in summary, I'd like to just say that, different surveillance systems can really result in different estimates. Different methods for examining geographic differences can also result in mixed findings with respect to how estimates vary. And there really are very few good examples of using immunization data to estimate variation within the population. Our study is probably the fourth study that has done this. And then when done correctly, this could be useful in identifying areas where research could highlight reasons for hesitancy or where education efforts might be targeted, such as in precision public health strategies. I'd like to acknowledge some of my collaborators. It really took a team of scientists and students and scholars to make this work happen. And of course, my funding from the Cancer Center, as well as funding that helped support a postdoc working on this project. And of course, Christy Gray from the Division of Immunization at the Virginia Department of Health. So thank you very much.